Good afternoon. I'm Dr. Brinda. I'm here to present a paper on ST-OCT based study of retinal nerve fiber layer changes in chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease is a multi-system disease which is characterized by persistent and progressive airflow limitation due to inflammatory response to noxious gases or particles. The chronic hypoxia and the associated inflammatory cytokines initiate many pathways with resultant systemic effects of COPD. As the retina consumes an enormous amount of oxygen for conversion of light to an electrical signal, it is in constant need of oxygen supply to maintain its structural and functional integrity. Systemic diseases with hypoxemia, like COPD, affect the ocular perfusion pressure and cause retinal hypoxia and ganglion cell death. Optical coherence tomography is a non-invasive and a quantitative technique that is widely used for diagnosis and follow-up of ocular involvement in systemic disease. It provides high-resolution cross-sectional images of the retina, optic disc, and RNFL thickness. Aim of my study was to assess the retinal nerve fiber layer changes using ST-OCT in COPD patients visiting a tertiary care center in Kerala and to compare the findings with healthy control group. Materials and method. The study design was a comparative cross-sectional study. The study setting was in the Department of Ophthalmology and the Department of Pulmonary Medicine in a tertiary care center, and the sample size was 15 in each test and control group. The various inclusion criteria were: Group A included COPD patients of age more than 40 years and on treatment since 3 years, with a visual acuity of 6 by 36 or better, intraocular pressure less than 21 mm of Hg, and a good OCT signal strength. Group B included age and sex matched non-COPD patients. The various exclusion criteria were: age less than 40 years, patients with a recent ocular surgery, patients with diabetes, hypertension, obstructive sleep apnea, patients with glaucoma, macular degeneration, retinal detachment, or any posterior segment pathology. Method of data collection was: patients were divided into Group A and Group B, that is the COPD and the control group, and then they had a detailed history and examination, following which an OCT RNFL was taken, which was used for comparison. The results of my study were: 30 eyes of 15 COPD patients and 30 eyes of 15 healthy individuals were evaluated. Out of the 15 participants, 10 were males in each group. The mean vision and the mean intraocular pressure in both groups were comparable. OCT optic nerve analysis was done using an ST-OCT. The first one is an OCT image, ONH image in a normal healthy individual, while the second one is the age and sex matched COPD patient which is showing RNFL thinning. Using an independent two-sample t-test, significant RNFL thinning was detected in superior, nasal, temporal quadrants as well as in the average RNFL thickness. Inferior quadrant also showed RNFL thinning, but it was not statistically significant. This is a table showing the RNFL thickness analysis between the COPD group and the control group. All the quadrants except the inferior quadrant showed thinning with a statistically significant p-value. Discussion. Tissue hypoxia, inflammation, and oxidative stress are the main underlying pathology responsible for systemic effects in COPD. OCT helps in assessing the retina, optic disc, and RNFL thickness. A study conducted by Nasser et al. Reported significant RNFL thinning in COPD patients in all quadrants except the superior one. They attributed the findings to the severity of COPD. And the study conducted by Vishalvak et al. Found significant RNFL thinning in mild to moderate and moderate to severe cases, which correlated to disease severity. Study conducted by Urgulo reported RNFL thinning in all quadrants in COPD patients, although significant thinning was present only in the inferior quadrant. Our study also showed significant thinning in the average RNFL thickness as well as in all quadrants except the inferior one. A study conducted by Kosamix and Zorlo et al. Found no significant difference in the mean RNFL in COPD patients compared to the control group, which was contrary to our study. In conclusion, COPD is a systemic disease with significant social and economic burden. The chronic inflammation and hypoxia in COPD causes oxidative stress, which result in axonal loss and ganglion cell death, the end result being the decreased RNFL thickness. OCT RNFL evaluation can be used as a screening tool for providing early intervention to prevent the visual outcome in the COPD patients. Limitations of my study were: smaller sample size. The severity of RNFL was not taken into account, which would have provided a better comparison and correlation to the RNFL changes. These are my references. Thank you.